Before diving in, I often think that it's a good time to start and look at the background and why clinical reasoning has actually become quite a hot topic in medical education, but also nursing education as well. So in this presentation, we're going to take a look at the background of clinical reasoning and why it's become quite important that we actually start to educate people in clinical reasoning. Before we started, I asked you to consider what are some of the basic requirements of a good clinician, and these are really basic things. Some things that we often say is that we hope that the doctor or the nurse practitioner or the advanced practitioner would be empathetic towards us. We would also hope that they get the diagnosis right, that their hands are warm, that they have a warm manner, that they follow evidence-based practice. But if we look at Cooper and Frayne, the most simple thing that we can actually hope for is that the practitioner has correct diagnosis and correct management. Correct diagnosis relates to their knowledge behind the disease condition, and then ability to diagnose you in terms of taking your history, clinically examining you and relating those to signs and symptoms of disease processes. Correct management simply relates to their decision making. So what is their decision making process, and have they got any flaws within their decision making process so that you arrive at the correct management. So when we boil it down, there's only two things that we really want from a doctor or a nurse practitioner if we're thinking of a treatment of a condition: correct diagnosis and correct management. So how do we actually define clinical reasoning? And it's loosely defined in the literature. The one that I like best is from Cooper and Frayne 2016, the ABC of Clinical Reasoning, which is a really good text to get you started on some of the intricacies and the ways that we think and the methods and the theory behind clinical reasoning. And I'll just put this definition up. So if we just examine this definition a little bit, I've taken the liberty of putting some of the important bits in red. And it's really the clinician's ability to make decisions, often with others. And what that's saying is that ideally we shouldn't be making decisions on our own. We should actually be involving both the patient and other practitioners. And as you'll see during the course of this module, these are things that can help us negate clinical biases and also avoid those pitfalls of making a wrong decision. It's based on available clinical information that we have from the patient, but also other systems, which includes the history, and sometimes that comes from multiple sources as well, and we have to piece that all together in our mind in something called illness scripts, which we're going to talk about a little bit later. Next, we have our clinical examination findings and test results. That goes back to our knowledge, being able to clinically examine patients and also gain a history and actually test them. And this is against a backdrop of clinical uncertainty in terms of what is the probability of the disease process, but also other factors that can impact our clinical decision making that we'll take a look at a little bit later in this presentation. So what are the components of clinical decision making, and can we actually teach it? And the most recent evidence suggests that we can teach it, but it requires students to have a certain level of background knowledge, which we'll explore later. The first thing in terms of clinical reasoning is obviously clinical skills, and this includes communication skills. We're talking about communicating with the patient in terms of having a system enabling you to get the history from the patient and examine the key points, but also clinical skills in terms of examining the patient and or ordering the appropriate tests. Understanding cognitive biases and human factors is really important. These are two separate sessions that we're going to look at. Your consultation with patients has the chance to fall into multiple pitfalls that are both your biases but also the patient's and other people's biases as well. We talked briefly about the patient who comes in and classically says, "I think I've got a chest infection," and that automatically places that they might have a chest infection in your head, whether they do or whether they don't. And these are some things that we're going to explore later. Finally, critical thinking and metacognition is something that we can employ when we talk about the systems of memory a bit later on, that we can use in order to try and negate some of these potential pitfalls. Finally, we should always be practicing patient-centered evidence-based medicine. And this is medicine and healthcare practice at the center, where the patient is at the center and we've got their best interests at heart. And sometimes this even means taking a decision not to treat the patient or taking a watch and wait approach. We don't always have to treat. And this is employed and overarched by something called shared decision making, that we're including the patient within our shared decision making process. So why is clinical reasoning important, and why are we now trying to teach practitioners how to clinically reason effectively? The first is that diagnostic errors are really a high priority within the health service as well. Not only does it cause morbidity and mortality to patients, but there's also big financial implications as well, and also publicity implications for the healthcare service as well if multiple errors are made. If we take a look at some of the recent studies, In 2018, out of case notes of 2,000 patients, approximately 61% contained misdiagnostic opportunities. And these are for a multitude of reasons. It's not necessarily placing the blame on the practitioner. It can be external sources, but usually these are faults in clinical reasoning by the practitioner. So being able to debias yourself and clinically reason appropriately is really important. If we take a look at national figures as well, and these are from the Department of Health, which examine serious untoward incidents nationally every year. Last year there was about 850,000 serious untoward incidents. Around 65 were a near miss, where there was no harm to the patient, but potentially there still could have been harm. 25% were low harm, and 10% involved some level of harm or morbidity and mortality to the patient. These are all clinically reasoned decisions that have been made, either rightly or wrongly, that have caused a near miss, low harm, or death in some cases. So clinically reasoning appropriately and teaching it is really important. So where do these errors come from, and how can we classify them? We can classify them in three ways, and the first is that there's no fault. And this is some things that are out of our control, such as it's an unusual presentation that we've never seen, or it relates to another disease pathology, or it can be some missing information as well, either from the patient or from a system where you're gathering information. And I'm sure you've all had it where you look for a clinic letter and it's not there, and you're missing information, have to acquire it from the patient or continue your consultation without. And this is not your fault, but it can provide an opportunity for an error to creep in clinical reasoning. The next is system errors, and we can divide these up into technical and organisational. Technical errors are relating to the systems that we employ, such as an X-ray not being available, blood test not being available, or not having the capacity to test as well. Organisational relating to more of the things that we have at an organisational human factors level. Things like understaffing, rotas that aren't appropriate, that have staff doing late nights and weekends and not abiding by the working time directive. You might be working in an area that is not appropriate to see patients. It's noisy, cramped. These things can have an impact on your decision-making ability as well. And the final one, and the big one, is human error. And this is where we make the error. This can relate to knowledge, like we talked about previously in the ideal clinician, that faulty data gathering can happen in that we haven't asked the appropriate questions or been able to elicit the history from the patient well enough. We can also have inadequate reasoning in that we react purely on intuition and we don't clinically reason on what could actually be the problem. And also practitioners, especially at the early stages of training, this is where the pitfalls can happen, and they can have a lack of knowledge as well. And as I'm sure you can appreciate, a lack of knowledge about a sign or symptom can relate to you not finding the appropriate disease pathology to diagnose the patient and treat them. So this can have a big impact as well. And finally is the unconscious biases that we're all subject to, which we're going to explore later in the module.